available on the Washington Community of Practice resources site at some point after today's broadcast. So our presenter today is Dr. Christine Garver-Apgar, BHWP's Research Director. Dr. Garver-Apgar earned her doctorate in experimental psychology from the University of New Mexico in 2008 and subsequently completed a postdoctoral fellowship at the University of Colorado at Boulder, the Institute for Behavioral Genetics, in 2011. She then served as the senior statistician for a research group within the Department of Psychiatry here at the Anschutz Medical School until 2014. As research director for BHWP, she develops, implements, and oversees several programs for both for us as well as our partner agencies. Thank you all very much, and I hope you enjoy today's presentation. Christine, you should hit the, I'm going to stop sharing my screen, and then you can start to share yours.
Sounds great. Let's see here. Here we go. I think this will do it. Let's see. Okay. Hopefully everybody is seeing my screen now, I hope. Okay.
Yes, we are.
All right. Let's see here. Let me see if I can advance. Oh, I can't. So maybe I'm not showing my screen, Jim. Well, let me try that again.
Try to use, when you get your screen back up there, just try to use your mouse for the first couple slide transitions, and that should help you take over. Just to the bottom left there, there's an advance arrow.
Oh, okay. Here we go.
There you go.
All right, more business. Thanks, Jim. Okay, oops, here we go. I have no conflicts of interest. That's important. All right, well, thanks everybody. I'm so happy to be here presenting to you today. And I know that some of you have attended our TTS presentation and others of you have not. This is a webinar about medication-assisted therapy, but I'm not going to spend, a whole lot of time introducing all of the specific tobacco cessation medications in great detail. Instead, I'm going to try to move beyond basic knowledge of tobacco cessation medications and discuss how to really maximize pharmacotherapy's effectiveness. What's up on your screen now is a link to a video of another webinar I conducted, so that if you do need more basic information about all of the FDA-approved pharmacotherapies for tobacco cessation, you can go to this link to a YouTube video. Some of the information will overlap a little bit with what I'm presenting today, but much of it offers more of an introduction to pharmacotherapy, I would say. So, so this is available for you if you find that you do need this, this information. Okay, so this is the agenda for this hour. In the first section, I'm going to describe critical things that both clinicians and clients should know about nicotine addiction, cravings, and withdrawal in order to maximize their use of cessation medications. And in the second part of today's webinar, I'll discuss ways that clinicians can better prepare their clients to make a quit attempt with the help of cessation medications through education and discussions about assessment and proper dosing and how to use medications, strategies to increase medication adherence, and then finally information about preventing relapse, but also of course addressing it when it occurs. So we'll start out by talking a little bit about nicotine addiction and why cessation medications are helpful. Not because anybody attending this webinar needs convincing that nicotine is an addictive drug, but because sometimes our clients aren't really thinking about the physical addiction. And so having this discussion with some clients can be a really powerful way to dispel the myth of willpower as something lacking somehow in someone who hasn't yet had success quitting tobacco. It's also important that clients understand nicotine addiction so that they can develop proper expectations about what tobacco cessation medications will and will not help with, and why medications themselves are not addictive. Individuals with addictions to other substances, such as alcohol, heroin, or cocaine, will very often report that tobacco was the most difficult addiction for them to overcome. So it's no surprise that more people who try nicotine become a daily user than those who try other drugs. So why is it that nicotine is such an addictive drug? So some of you have heard me talk about this before. Part of the reason is that tobacco companies have spent many, many decades now perfecting how to get nicotine to the brain as fast as they possibly can, because we know that the faster nicotine gets there, the faster an individual experiences behavioral reinforcement from smoking, and the more addictive it becomes. So each cigarette delivers about 1 to 2 milligrams of nicotine. And that's, of course, important to know when we start talking about dosing nicotine replacement therapy. And after a person takes a puff from a cigarette, nicotine from that inhalation will reach the brain within 10 seconds. We know that if a person had injected themselves with nicotine, it would not reach the brain nearly that fast. And because it reaches the brain so fast, smokers can easily control how much nicotine they're getting. And that makes cigarette smoking more reinforcing than getting nicotine any other way. And it's also why nicotine from other sources, like nicotine, like the patch and the gum, have a much, much lower potential for abuse. Okay, so this slide just summarizes abstinence rates for the different treatment strategies, starting with no treatment at all. Clinicians can help clients understand that unaided quit attempts, which is shown up here at the top, are not often successful. And this doesn't indicate a problem with willpower for the reasons that we've been talking about. All of these techniques are effective compared to no treatment at all, but you can see that a much higher percentage of people who receive medication and counseling together are able to quit using tobacco, compared certainly to no assistance whatsoever, but even in comparison to some of these other types of assistance, including medication just by itself or counseling just by itself. And clients should understand that the reason counseling and medication together are the most effective at treating tobacco dependence is because tobacco dependence has two parts. Pharmacotherapy addresses the first part of tobacco dependence, or the physical addiction to nicotine, whereas counseling addresses the second part of tobacco dependence, or the habit or the behavior surrounding tobacco use. And I know some of you are familiar with this slide, but it's important for clients to have realistic expectations about how tobacco medications are likely to help. They help with the physical craving for nicotine, but they don't replace counseling to change behavioral habits. So I think this is really important to move beyond our own understanding for this two-part problem and to really help clients understand what medications can and cannot help with, because it's an initial part of helping set reasonable expectations for our clients when it comes to pharmacotherapy. Okay. And so this slide lists the 7 medications approved by the FDA for smoking cessation. 5 of these contain nicotine, and they're called nicotine replacement therapies. 2 of these do not contain nicotine. 3 of the NRT medications are available without a prescription. That's the nicotine patch, the gum, and the lozenge, whereas the remaining medications require a prescription. As I mentioned, I'm not going to go into great detail about each of these medications. They're all effective, as you'll see on the next slide. And so as we'll talk about sort of throughout this presentation, the best one to use is the one that patients want to use and will use as recommended. Okay, just 1 or 2 slides here on the efficacy of these medications. This is a bit from a large review of clinical trials looking at the efficacy of pharmacological interventions. So this chart is just reviewing several different meta-analyses in which data from lots of different studies are pooled together. What I just want to briefly show you is that NRT, bupropion, and varenicline all improve the chances of smoking cessation at 6 months compared to a placebo. So NRT and bupropion increase the likelihood that a person will be abstinent from tobacco at 6 months post-quit by about 60%, whereas varenicline more than doubles the likelihood of abstinence at 6 months compared to a placebo. That's what those numbers in red are illustrating. So they're all effective, is really the take-home message here. Long-term quit rates, this slide gives just a snapshot of quit rates maintained over a 36-month period across all the FDA-approved medications. Quite simply, quit rates for individuals who use some form of cessation medication, no matter which one they use, are higher than for those individuals who used a placebo. That's really the take home here. No matter what medication you're using, the quit rates are always higher compared to a placebo. So nicotine addiction is no different from any other addiction. People use addictive substances because there are rewards from using them. And, we're talking about biological rewards, things like feeling aroused or feeling pleasurable effects. All drug addictions involve a physical dependence. That means experiencing both tolerance to a drug, but also withdrawal. So as tobacco users become more tolerant, they have to increase their nicotine use, either to get the same biological rewards or simply to avoid symptoms of withdrawal. And of course, that leads to greater craving and then greater addiction. When people stop using tobacco products, and depending on their level of use, they'll likely experience some or all of the symptoms that are mentioned here. Usually that comes with a really strong craving or desire for tobacco. They can also experience symptoms of depression, because taking away nicotine has the effect of reducing dopamine and serotonergic activity in the brain. So in general, withdrawal symptoms appear within the first 1 or 2 days. They peak within the first week, and then they decrease over the next 2 to 4 weeks. But cravings and urges for cigarettes, as we know, take much, much longer, even months or years to go away. Cessation counseling helps, of course, to address the behaviors or the habits surrounding tobacco use. But when someone is experiencing symptoms of physical withdrawal, we know that counseling is not particularly effective, and that's why pharmacotherapy in combination with counseling is so effective. Cessation medications really work by helping to alleviate those symptoms of withdrawal so that people can focus on working to change their smoking behavior. And that's an important message for clients, that while medication can be very helpful, it often isn't the entire solution. All right, and I'm going to just go over this addiction cycle that some of you have seen before, but I think it's important for those of you who haven't. This is a figure that depicts the typical nicotine addiction cycle that a cigarette smoker might experience on a daily basis. So this is just a hypothetical chart. What it shows here, the jagged line represents a venous plasma concentration of nicotine as a cigarette is smoked every 40 minutes from 8 a.m. to 9 p.m. The upper solid line here indicates a threshold concentration for nicotine to produce pleasure or arousal. And the lower line indicates a concentration below which a withdrawal symptom would happen. So anything above the line people would feel good. Anything below the gray area, people would start to feel pretty lousy. And then the gray area just indicates a level of nicotine where people would just kind of feel okay. They wouldn't feel super good. They wouldn't feel lousy. They just feel fine. But what I want you to notice about this figure is the arousal or pleasure that people experience after smoking the first cigarette of the day. So you can look down by the 8 a.m. Mark, and nowhere else on that graph do you see that line go so far into the pleasure zone. And that's why many smokers will say that their most important cigarette of the day is the first one. And how quickly someone smokes that first cigarette of the day after they wake up is an indicator of tobacco dependence. The reason that the first cigarette is the most pleasurable one is because tolerance starts to develop shortly after that first cigarette. And so as the smoker becomes more and more tolerant to nicotine throughout the day, they get less and less pleasure out of each successive cigarette. So by the time, dinner time rolls around, or 6 p.m., you'll see that that line is never actually getting out of that gray zone. At that point, people are smoking just to feel okay. They don't get any pleasure out of it anymore. They're just smoking, not to feel lousy anymore. And so overnight, a smoker becomes resensitized to nicotine, and then the cycle starts all over again the next day. And this figure also explains why you will commonly hear in trainings, including this one, that a common recommendation is to take a gum or a lozenge immediately upon waking to boost that steady nicotine being offered in the patch. But the medication does take 15 to 20 minutes to work from the gum or the lozenge. And so a client won't experience an immediate sense of relief with that strategy. And it's really important that they realize this. Okay. Let's see. All right, so I want to turn now a little bit. So that part was a lot of review for some of you, but I want to move now toward continuing the theme of how to better prepare clients to make a quit attempt using tobacco cessation medications. So we're going to talk about how to administer a validated assessment of nicotine dependence and just give some key tips and tricks that are important to know when using particular medications, especially NRT. And I'll talk about strategies to help clients and clinics with medication adherence and how to help clients prepare for relapse when and if that happens. Okay, so I want to start by talking a little bit about tests for nicotine dependence. One of the best ways that clinicians and providers can help prepare clients for an effective quit attempt using medications is to get the right dose. To do this, it's a very good idea to use a validated assessment tool as a starting point for dosing NRT. The two prescription medications that don't contain nicotine have much more regimented, standardized dosages. So I'm only talking about nicotine replacement medications here. The Fagerstrom test for nicotine dependence assesses a person's physical dependence on nicotine, not surprisingly. It has 6 questions, which are listed here, and this is validated for adults. There is also a version for adolescents called the MFTND. The 2 items in the orange, let's see, here's the orange rectangle that are shown here. Are together, these 2 items make up the heaviness of smoking index. The reliability of the HSI, that's the heaviness of smoking index, is comparable to the Fagerstrom test, although there is some evidence that would suggest that if a person is not highly dependent on nicotine, then the full measure is preferable, the full 6-item measure. But both assessments are short, especially this 2-item version here. They can both be adopted into current workflows without a whole lot of effort. They're both very easy to score. You would just add up the points that are shown here on the screen in green. So this chart serves as a rough dosing guide, which corresponds to the scores on these 2 assessments. Scores on the full measure range from 0 to 10, with 10 being highly physically dependent on nicotine, and scores on the HSI range from 0 to 6, with 6 being highly dependent. From a clinic management point of view, adopting the Fagerstrom test or the heaviness of smoking index test into workflows provides the clinic another way to evaluate whether patients are being delivered quality evidence-based care. Because for one thing, are clients who use tobacco having their dependence assessed? And 2, if they are they being recommended or prescribed the baseline level of NRT? These scales provide a way of making those, answering those questions. So here, before I go on, I just also wanted to provide a link to a quick reference tool that we have created at BHWP summarizing FDA-approved cessation medications, the assessment tools I just showed you, the dosages, and the dosing schedules. So that's available. Those tools are available for you here. Okay. So a few other points I wanted to make about dosage. When a provider talks to a client about dosage, they should communicate that they've gotten a dosage recommendation from a tool, and also that the tool provides a conservative dosage. And unless the provider has other reasons to expect that the client needs more, the recommendation is a good place to start. However, clients and clinicians should know that nicotine is frequently underdosed. And this can be for a variety of reasons. So for one thing, as I mentioned earlier, each cigarette delivers anywhere from 1 to 2 milligrams of nicotine. This is actually quite a large range. That initial dosage is based in part on how many cigarettes people smoke per day, but it seems to assume that that lower level of nicotine is absorbed per cigarette. But that may not be true for everyone. And so we can look at a quick example using our assessment tools. So here's the Fagerstrom test again. If we look at just these top 2 questions, let's say that a person selects for question number 1, let's say that upon waking, a person says that they smoke a cigarette within 5 to 30 minutes upon waking. So for question number 1, that would earn them 2 points. And then for question number 4, the one beside it, also in the orange rectangle, let's say that they smoke a pack a day. That would be 20 cigarettes. And so for that answer, they would earn 1 point for number 4. So that would give this person a total score on the HSI of 3. They would get 2 points for question number 1, and they would get 1 point for question number 4. So if we go then to our scoring sheet, a score of 3, we can see down on the HSI, gives that person a score of low to moderate physical dependence on nicotine, and a correspondingly relatively low dose for the patch. That person would start at 14 milligrams. So in this case, a person could very well be underdosed, especially if they're a person that takes in closer to 2 milligrams of nicotine per cigarette. There's also a lot of individual variation in terms of how quickly a person metabolizes nicotine, and that can impact physical dependence. And moreover, many people, of course, simply underestimate how much they're smoking. So for these and other reasons, many people will find that the initial recommendation for NRT dosage that they were given is not effective for them. Um, and it's important for both clinicians and clients to know that it's really hard to overdose on nicotine. People who are taking too much nicotine start to feel really lousy and sick long before they experience any significant, long-term consequences of too much nicotine. So if a client is taking NRT as it has been recommended to them, and they're still having high levels of cravings, they should not hesitate to either increase the dose themselves or to make another appointment to talk about increasing their dose with a provider. There are several strategies for using FDA-approved cessation medications that both providers and clients themselves should know about. Researchers have found that cessation rates are higher when individuals used combination therapy rather than just using one at a time. So these are the current clinical practice guideline recommendations for using combination therapy. It is considered safe to use the patch along with any other form of NRT. It is also considered safe to use bupropion with either the patch, the gum, or the lozenge. So these can be used in combination. And a very common combination, as I mentioned earlier, is to use the patch and then to use the gum or the lozenge for those breakthrough cravings. Another strategy to increase the efficacy of NRT is to start using it actually before the quit date. Providers have started using nicotine replacement therapies before an individual makes a quit attempt, and results from studies have shown that there are no increased side effects from this practice, and that it can even double the success rate, according to at least one study, of that quit attempt compared with using at least this was a study that looked at the patch. In this case, that compared with just using the patch on the quit date, at least this study showed that it can double the success rate of that particular quit attempt. One reason this may be helpful is because by using medication before a person quits, it helps to break that linkage between that emotional association with a cigarette and a cue in somebody's environment, something that would link a situation where a person would pick up a cigarette. When a person has the nicotine in their systems already, when those cues come along and a person has already reduced the amount of cigarettes they're smoking because they've already got all that nicotine on board, it helps to start breaking those associations with those habits before the person even quits smoking. So it can be really helpful as a way. We talked about how helping a person to be comfortable while they're working on changing those behaviors. But if a person starts to do that work before the quit date even comes around, that can really help to build up a person's confidence that they are going to be able to quit, because they've already sort of started doing that work before the quit date even rolls around. So that's one idea about why starting with these medications before the quit date can be so effective. All right, so I want to talk about a little bit about adherence, medication adherence, and dosing schedules. So, which medication is best? We know that the best medication is still the one that clients will adhere to and take as recommended. And really, personal characteristics of clients is really going to determine which medication they're interested in taking. But one common finding in the medication adherence literature is that the more complicated a treatment plan is, the less likely it is to be followed with fidelity. And so, in general, fewer doses per day is better in terms of medication adherence. And if we translate that to tobacco cessation medications, what this means is that the patch then should be the best, followed by varenicline or Chantix, and then bupropion, and then the gum or the lozenge. A traditional gum or lozenge regimen would be for the client to take 12 regularly spaced out doses per day. And then if it's determined necessary by the dependence level to then supplement that, with the patch. But 12 regularly scheduled doses is really hard to follow with any sort of precision. But as I mentioned, the problem with giving a conservative amount of nicotine through the patch and then supplementing that with the gum or the lozenge on this as needed basis is that the gum or the lozenge does take 20 minutes to address that craving, and the client is vulnerable to lapse or a relapse in that time. So in keeping with the idea of simplifying the medication regimen, and moving clients toward treatment plans requiring fewer doses, or if a client is having difficulty managing multiple forms of NRT, a client could consider just taking a higher dose of the patch, especially if they're having lots of cravings, or if they find themselves having to use the gum or the lozenge, all the time. If a client likes the idea, though, of multiple modalities of NRT, and they like having something to deal with cravings, they should just know that those medications don't work immediately. And this is where, counseling really comes in. Given the gum or the lozenge take a while to work, you can encourage clients to anticipate times of high cravings and actually perhaps take the medication before a craving is likely to begin. So this just goes to this idea of, helping clients to set the right expectations about how these medications work and how to use them. And there are a few tips for just actually using these medications effectively. Uh, those of you who attended our TTS got a lot more information about this, but the patch and some of these other forms of NRT, it's amazing how many people just actually don't know how to use them the right way. And this, of course, does reduce their efficacy quite a bit. It's helpful to provide clients with actual instructions for how to properly use these medications. We think of them as being pretty easy to use, but if you don't walk them through, they really can be a little bit tricky in some instances. So the patch, if it's not properly applied, it will fall off and it won't work right. It doesn't withstand water very well, including sweating with exercising. So these are things clients should be aware of. Clients think you can cut the patch and that to get less of the medication. It doesn't work because then the client gets too much of the medication all at once, and the sustained release aspect of the patch doesn't work properly if the patch is cut. So it does impact the efficacy of these medications. So really helping the client to know how to use these is quite important. With the gum and the lozenge, it's important to chew each piece slowly. Some people think that you chew the gum the same way you would chew any gum. This is not true of nicotine replacement therapy gum. What you want to do is chew it until it releases a peppery taste or the client gets a tingly feeling, and then you want to park that gum in between the cheek and the gum. And that's actually when the nicotine is being absorbed. If you chew it and just swallow all the time, what's happening is the nicotine is just going into a person's stomach. And so it's actually not being absorbed properly. But again, if a client doesn't know this, then they'll think these medications are not effective when actually they're just not using them correctly. So these are really simple things that that are pretty important. Also, of course, with the gum and the lozenge, clients shouldn't have any acidic drinks like juice or coffee or wine for 15 minutes before they use the gum or the lozenge. That reduces their efficacy quite a bit. Okay, there are a few other ways to prepare clients for using cessation medications that are in keeping with this theme of helping clients set expectations and also become engaged agents of their own tobacco cessation goals. First, many clients have tried NRT before. They may have received advice or warnings from friends and family members about medications, and so part of setting expectations may involve exploring with the client what they currently know about NRT and how they came by that knowledge. Because in some cases, clients may not have received accurate information. Another discussion to have with some clients is that it's really difficult to become addicted to NRT, unlike other forms of tobacco, especially cigarettes. And this is a concern for a lot of clients. So for people who are interested or concerned about this issue, providers can explain about why that is, so that nicotine from NRT doesn't reach the brain nearly as fast as nicotine through cigarettes. And because of this, it's much, much less reinforcing. Clients should, if they can, they should practice using pharmacotherapy. Some research even suggests that actually sampling different medications improves adherence and cessation. There's also a belief held by both providers and clients that the mode of NRT delivery will be most effective if it matches the client's current mode of tobacco use. So, in other words, for a client who smokes cigarettes, that would mean using the inhaler because they're both inhaling mechanisms. If you use snuff, then you should use the nasal spray. If you are using chew, then you should use the gum NRT. So, but there's actually no evidence that this is true. So adjusting from one form of NRT to another, it really should not affect the efficacy of the medication. And in general, just being flexible with patients, experimenting with what works for individuals, and troubleshooting really seems to be important for finding a medication strategy that works and that patients will stick with. And of course, it is important to acknowledge that allowing clients to experiment for a couple of days or a week with different versions of NRT or different kinds of medication, that does mean arranging follow-ups with clients so that they can discuss their experiences and determining the best treatment plan. So it does take, there is some more effort involved on that end. So I just want to acknowledge that, but it does seem to be that the flexibility here is more key. There's another thing that is really important for both providers and some clients should know when they're getting prepared for quitting tobacco. People on psychiatric medications require some special considerations when they quit smoking. This is because the system that metabolizes many of the toxins and carcinogens in cigarette smoke is the system that processes psychotropic medications and caffeine, as it turns out. And it's important because tobacco cessation can affect the blood level of many different types of medications, including psychiatric medications. So, as tobacco users metabolize nicotine and other chemicals in cigarettes, they tend to more quickly metabolize prescribed medications. So, when an individual quits smoking, the blood levels of many of their other medications can significantly and sometimes dangerously increase. Sometimes side effects of higher dosages of prescribed medications are confused with nicotine withdrawal or psychiatric symptoms. And then tobacco use and cessation has the same effect on caffeine. So individuals who are drinking lots of coffee might not be, or caffeine from other sources, they might not be able to tolerate those same levels after they quit smoking. So if an individual reports increased anxiety, just as an example, it could be due to the amounts of caffeine that they're continuing to use, and not, it might not actually be a withdrawal symptom, even though it can look a lot like that. So it's important that prescribing providers are aware that their patients are quitting and that they need to monitor their medication levels. But it's also important that clients themselves understand these really important relationships between smoking cessation and their psychiatric medications. And what this chart has on it is this is a list of medications that are known or suspected to have their levels affected by smoking and smoking cessation. And I also want to mention that NRT does not do the same thing. It should not present the same concern. So the metabolism impacts are mostly, it would appear, not actually metabolizing the nicotine, but rather metabolizing all the other stuff in a cigarette influences metabolism in this way. So if a person is going on and off NRT, they should not have to worry about the blood levels of these psychotropic medications going up and down the same way they would if they're if they're stopping a cigarette. So here, this chart is available for you. But the important point is that prescribing providers need to be aware if a person is stopping tobacco use. Okay, and now just a few slides about relapse and relapse prevention. One of the ways that providers can help clients set realistic expectations is, of course, to discuss lapses and relapse. A lapse here refers to an isolated use of tobacco, whereas a relapse refers to a return to regular tobacco use after a period of abstinence. According to epidemiological studies, the risk for relapse during the first 12 months is over 50%. So it's high. Relapse prevention starts at the beginning. It begins at the initial assessment. We don't just pay attention to it after a relapse happens. And we'll talk about this a little bit more on the next slide, but initial and follow-up counseling really focuses on learning to anticipate and cope with the challenges that often lead to relapse. And since we're talking about pharmacotherapy, what's important here and what clients and providers need to know is that if a client has a lapse or a relapse, what we don't want them doing is stopping their cessation medications. They should continue their medications. And this is often something that clients worry about when they have lapses or relapses. And so it's important that this gets discussed before a quit date happens, because this goes hand in hand with, planning and making sure that that clients have set proper expectations with regard to their medication and what should they do if they have a lapse or a relapse. So Any smoking at all, particularly in the first 2 weeks of a quit attempt, will significantly increase that relapse rate. Most relapses occur within the first 3 months of abstinence. And then after 1 year, the risk for relapse decreases more and more each year. Not surprisingly, people who are preparing to stop their tobacco use should remove tobacco and tobacco-related products from their environments. Part of counseling and preparing for these lapses and relapse situations is to identify high-risk situations that might trigger a relapse, and really helping individuals prepare and plan for how they're going to handle these situations when they come up. Because ultimately, this preparation and planning helps to build confidence. The more people are engaging in these tobacco-free behaviors or other behaviors that might facilitate their well-being, and the more they can, make changes to their environments that will allow them to prepare for these eventual high-risk situations, and how they're going to move through these situations, that really is going to help to build their confidence that they actually can live a tobacco-free life. So I want to talk a little bit about adherence strategies. This slide lists a bunch of things, and it is true that adherence interventions that involve multiple components have been shown to be best. But it's also true that providers should take care not to overcomplicate the treatment plan for their client. Um, Look for strategies that already align with a client's treatment plan. And so this slide lists a few things that different sites could consider in some cases. And I just want to highlight a few of these as examples of how NRT adherence could be attached to other protocols that might already be in place. So for example, if a client already has a case manager or an aide that goes to the client's home for the purpose of monitoring, let's say, a medication for schizophrenia, then have that individual observe the NRT medications as well. If a client is already in family treatment, be sure to communicate to the family therapist that the client could use some additional assistance with NRT adherence, if that's the case. So when training behavioral health providers, suggest that relapse plans are a part of treatment plans. So these are just, so I think creatively trying to think about ways that these adherence strategies for NRT can be incorporated into current workflows with the least amount of new work as possible are what we want clients and sites to be thinking about. And we've talked about how providers want to avoid making treatment more complicated than is necessary. Medication adherence protocols do complicate the treatment plan for the client, and they add additional oversight tasks to the clinic or the clinician. So we don't necessarily add medication adherence protocols to everyone, assuming that everybody will fail to comply. But we try to identify those individuals for whom medication adherence might be an issue. And so to summarize those 3 bullets in the top banner, there is a higher risk for medication noncompliance for those who tend to take more medication already, or for those who might not take medication already but who need them. So people who have comorbid medical conditions and or very complex treatment regimens. And then finally, of course, people who have higher dependence, higher nicotine dependence. NRT is great, but it is never going to be as good as cigarettes are in delivering nicotine. So a higher dependence just means that cravings are not going to be addressed as well with NRT. So whether a person is identified as higher risk or not, clinicians should still be on the lookout for clients that might not be taking their medications in the most effective way so that they can address those issues. Um, Signs, include these two listed in the second banner. So missing appointments or missing refills. And then finally, clinicians should simply be asking clients about their use and experience to determine if using these medication adherence protocols might be necessary for a given client or patient. Use this exploration time to determine what precisely might this patient's barrier be to compliance, and then try to adjust their plan accordingly. And I think that concludes everything that I have for you today. So I am going to turn this back over to Jim now. And I'm going to stop my share and let Jim resume the last few slides. And I think Jim's going to facilitate a question and answer period, if I'm not mistaken, as well.
Sorry, I'm over here unmuting my line. So, I do want to go ahead and open up the lines for questions. I do want to say that a recording of this webinar is being made, and we will post that on the Washington Tobacco Freedom Community of Practice resource site. If that is interesting to you and you want that link, just send us an email at bh.wellness. .org. I'm sorry, bhwellness.org. That information is also on one of the slides that I'll try to get back up in just a second. And then in addition to the actual recording of the webinar, we'll put up the slide deck there as well. Those of you who are in the community of practice have an easy way of getting that information. But for the rest of you, you can, like I said, just I'll put this slide up and you can jot down our email address. There we go. All right, and again, I'll open up the line for questions. You can chat in questions, or you can use the Q&A button, or you can raise your hand. If I see that your hand is raised, then I'll go ahead and just unmute your line. Go. So hopefully you're all seeing that slide with our email address on it and our website. Our website is www.bhwellness.org, and our email address is bh.wellness@ucdenver.edu. And either one of those should be able to get you to the slide deck and the recording of the webinar. Okay, for those of you who are in the community of practice, I don't actually have the dates in front of me, but do keep in mind that we have our community of practice call, our learning community call, coming up in a week or two, and it'll be roughly the same. It'll be the same day, Mondays at 1 for you. Please go ahead and get that on your calendar and be prepared to join us. During that time, we'll briefly recap the high points of this particular webinar. If you do need other nicotine replacement therapy guidance or instruction, you can check out that link that Dr. Apgar put at the beginning of the presentation. You can find it on our YouTube channel. That is an hour-long presentation about what are the over-the-counter pharmacotherapies, what are the prescription ones, what are the nicotine-containing ones, what are the non-nicotine-containing ones, all the stuff that you would consider pretty basic. This one was a focus on medication adherence and other strategies to get people to use these medications. That is to say, what do we need to do, what advice we need to give to get them to work. Penny Andrews has asked, did we learn when nicotine replacement therapy will be available? And we, I don't know, let's see, hold on just a second. Seeing if Nick is still on the line. I don't see Nick, but Penny, I'll get either Nick Fradkin or George Banks from the state to give us an update. Penny, I think you're in the learning community call if I'm correct. And go ahead and bring that question to the learning community call, and they'll be on the line with us. Nick or George will be, or both, and we'll get them to answer you all directly on that particular question. Hopefully the answer will be soon.